We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, APIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research. Hi, Nikki. I'm so glad to be back here with you.
I am glad to be back too, Jess. It's good to hear your voice again. Anything new or exciting in your world?
Well, I have to tell you, something interesting did happen. So I was abducted by aliens.
What?
I know, crazy, right?
Yeah.
So they made me wash my hands, clean my room, and eat my vegetables.
Do what?
It turns out I was on the mothership.
Were they all infection preventionists too?
They were.
Did they have ICRAs on the spaceship?
And linen handling processes.
Just keep them coming, keep them coming. Well, Jess, thank you. We have a really cool topic today. Dr. John Boyce and Dr. Richard Martinello are here with us today to talk about their article in the latest issue of APIC called Pilot Study of Using Thermal Imaging to Assess Hand Hygiene Technique. Dr. Boyce is currently president of J.M. Boyce Consulting, LLC, a position he assumed in 2015 after retiring from his positions as Director of Hospital Epidemiology and Infection Control at Yale New Haven Hospital in New Haven, Connecticut, and as Clinical Professor of Medicine at the Yale University of Medicine. He worked as a hospital-based infectious disease specialist for many years and as a hospital epidemiologist in several university-affiliated facilities over a period of 40 years, and now spends his time as an infection control and prevention consultant. He served as president of the Society of Healthcare Epidemiology of America, or SHEA, in 1999. He was lead co-author on the HCPAC APIC SHEA IDSA CDC guideline for hand hygiene in healthcare settings, something all of us IPs will know very well. And he was a contributing author to the WHO guidelines on hand hygiene in healthcare. He has co-authored numerous articles dealing with multiple aspects of hand hygiene. Dr. Richard Martinello is a professor of internal medicine and pediatrics at the Yale School of Medicine. He's a board certified in adult and pediatric infectious diseases and completed his residency in internal medicine and pediatrics at the Indiana University School of Medicine. He trained in adult and pediatric infectious diseases in addition to healthcare epidemiology at Yale. Dr. Martinello serves as the medical director of infection prevention for Yale New Haven Hospital and the Yale New Haven Health System. Dr. Martinello's research interests include the epidemiology and prevention of respiratory virus infections, disinfection of surfaces and air, and the prevention of healthcare-associated infections. Dr. Martinello was recently funded by the CDC to develop processes and recommendations to improve infection prevention and controls in hospitals, improve systems for identifying and tracking patients who may present risk to other patients or staff, and to develop a novel educational platform to improve the awareness and practice of infection prevention and control in healthcare. So welcome, gentlemen. We are very excited to have you with us today.
Thank you.
And Dr. Boyce, let me give you the honor of kicking us off today. Can you give us a rundown of what started this research project and just give us a little idea of what it entails?
Right. Well, I've been interested in hand hygiene technique for a number of years, but noted that in contrast to all the work that's been done on improving hand hygiene compliance, so far there's no widely adopted method for assessing hand hygiene technique. That is, how people apply the alcohol-based hand sanitizer to their hands.
Right.
So I was looking for maybe a new approach to assessing hand hygiene technique, and saw some material dealing with thermal imaging. And of course, when you apply an alcohol-based solution to your skin, it's usually at room temperature. And then as it evaporates, it pulls heat out of your skin. So your skin cools right where the alcohol has been applied. So I wondered if we could use thermal imaging to determine whether or not the sanitizer had been applied to all surfaces of the hands and fingers. So what we did is, for each of our healthcare volunteers, we initially measured their hand and then estimated their hand surface area using published formula. And then we divided the volunteers into 3 groups, those with small, medium, or large hands. And then for each volunteer, we had them put the palmar aspect of their hand on a desk, and we took a baseline thermal image using a small thermal imaging camera attached to an iPhone. Then we asked each person to apply about 1.8 milliliters of the hospital's sanitizer to their hands and to rub them together until they felt dry. And then immediately after that, we took a second thermal image of their hands, and then additional images 1 and 2 minutes later. Because a number of studies have found that sometimes healthcare personnel do not apply the sanitizer to their fingertips or thumbs, these were areas we were particularly interested in. And for one volunteer, we asked him to purposely avoid applying the sanitizer to his thumb, and we wanted to see if that was detectable on these thermal images. So that's kind of how we got started.
Great. Thanks so much for the comprehensive details of how this all worked. I have to say, I actually really appreciated the color photos in the article to sort of help see what exactly it was that you were looking for. So can you tell us next, as you're talking about doing the hand hygiene, and you mentioned the thumbs and you mentioned the palm, what exactly makes for good hand hygiene technique? What should people be focusing on?
Yeah, I think there's mainly 2 things that are involved in good hand hygiene technique. First and foremost is the volume of the alcohol-based hand sanitizer that is applied to the hands, because that directly affects how long it takes for you to rub your hands together before they feel dry, the so-called dry time. And dry time has been shown recently to be one of the major factors affecting antimicrobial efficacy. In other words, how well you reduce bacteria counts on your hands. A second factor is the degree of coverage that is achieved when you apply the sanitizer. And for good hand hygiene technique, we want to apply the sanitizer to all surfaces of your hand and fingers, including the fingertips and the thumb. So in my way of thinking, those are a couple of the major factors affecting good hand hygiene technique.
Thank you.
So you also mentioned that, we're focusing on hand hygiene technique, and we go over this in new employee orientation. But like you said in the paper, very few facilities routinely assess the technique. So I'm wondering, besides new employee orientation, and we might do just-in-time education if we see opportunities for improvement out in the hospital, but can either of you all talk about what other approaches hospitals might have currently to actually assess the technique?
I might invite Dr. Martinello to comment first on that, since he's currently, working in the hospital. And then after he has some comments, I could maybe add a few others.
Yeah. Well, unfortunately, we don't see as much opportunity being taken as is probably necessary. And, I think one example that I have seen is taking advantage of opportunities like Infection Prevention Week to set up tables in areas where our staff commonly are, and going over hand hygiene with them and that technique of hand hygiene. And, I think what John and I hope to see at some point in the future is possibly having this infrared assessment being available to help assess one's technique and making sure that they're covering all of those areas sufficiently.
And, I think having that interactive activity with staff, like you said, during Infection Prevention Week, what a great use of Infection Prevention Week. But even just as a kind of a side fun activity to do with IIPs and their staff is to utilize this. It's kind of fun for staff. Sometimes we'll culture hands and see what people are growing. So this would be another fun addition to that.
Yeah, I agree.
I might add that I haven't really seen good data on how many hospitals are routinely assessing hand hygiene technique. Some things that are out there that are possible are several automated systems. One system uses a video camera with integrated software, and it has the healthcare person put their hands underneath the video camera and then move their hands around as though they were performing the WHO 6-step method of using a sanitizer. And the system will give the individual feedback while they're doing this as to whether or not they have performed each of the 6 steps correctly or not. So that's an automated training system that's been around for several years. I don't know to what extent it's used in hospitals. Another system which has been used a little bit more in Europe also uses a video camera with integrated software, and it has the healthcare worker apply sanitizer to which a ultraviolet solution has been added. And then underneath the video camera, they perform hand hygiene while there's a UV light source showing their hands. And of course, with the UV light source, any parts of the hands that are not covered will be distinguished from areas that have been covered by the UV light. And you can get immediate feedback by looking at those images. Again, I don't know how frequently that system is used. And then, somewhat to my surprise, I recently noted that some of the new Apple watches have a function where you can ask it to record how long you spend cleaning your hands. And apparently the watch will tell you if you did it less than 20 seconds. I actually haven't seen that function work, but
weird. Wow, that's crazy.
It's something new that's coming along.
Yeah, so actually, our one of our hospitals actually uses that first technology that you mentioned. And the only comment that I'll make is that after using it and just, I think, seeing like the World Health Organization's moments, I will say that I do focus more on my fingertips and thumb than I ever have before. So I'll put that out there. Maybe that was a good educational opportunity for me. And then I will say that I do actually have a coworker who uses that timing on her Apple Watch. So I've seen her wash her hands and have it time her in doing that. So there are some things out there that are definitely I've seen being used, but I really like the concept of the thermal imaging because it, as mentioned in the article, you don't have to add anything extraneous other than, you're just doing your hand hygiene with that alcohol-based hand rub, which is really nice versus using something like another piece of equipment or the glow germ product that we sometimes use to detect when people are washing their hands adequately. But in thinking about people's hands and how this thermal technology works, it was noted that there is variability in the size and temperatures of people's hands. And I mean, I don't know how well this would work with me because my hands are ice cold all the time. But can you tell us how this variability then affected the results of the pilot study?
Well, we noticed that the baseline images of the different volunteers did differ in terms of some people having what you would call warm hands, and then some pretty clearly having what we would call cold hands. And the thermal imaging showed that people with cold hands, the temperatures were clearly lower in their fingers and thumb than a person with warm hands. And the people with cold hands, I think it's fair to say it was a little more difficult to assess how well they covered their fingertips and thumb because their fingers were already kind of cold with lower temperatures. So that could affect the overall practicality of using the system. But I think we need much larger studies involving many more healthcare workers to get a handle on whether that would actually be a problem or not. And then, of course, hand size is another factor that affected the results. People with small or medium-sized hands had greater reduction of their temperatures than people with large hands, probably related to the fact that we found a strong negative correlation between hand surface area and the volume of sanitizer applied per centimeter squared of their hand surface area. So, of course, a person with small hands, when you apply 1.8 mLs, they're going to have good coverage and quite a bit of alcohol in their hands compared to applying the same amount to large hands. And so hand size does affect kind of how much temperature reduction you see. And so that's another one of our findings that we noted.
Interesting.
Yes, I have large, cold hands, so that would be an interesting subject for your study. And I kind of want to direct my next question to Dr. Martinello just because of the setting that you're in. I'm curious as to how you guys see this being applied in a real-life setting, and along with that, the Hawthorne effect, which is, subjects altering their behavior because they know they're being observed. I'm wondering how we could avoid the Hawthorne effect when you're using it.
Sure. Yeah, thanks for the question. I think there's two major arenas where we could potentially use this. And let me first say that both will require a lot more research and development before this is ready to be rolled out. First, I think there's an educational opportunity, and we touched on this a little bit earlier. And it's many of the other technologies that are currently available, such as the UV powder that Dr. Boyce was mentioning, and many of us are familiar with, don't work well with alcohol-based rubs. And so this technique may provide us with a good option. So I think that educational use case is an important one. Second, and this too will require substantial research and development before it's ready, is one can envision an automated system for monitoring hand hygiene using infrared cameras within our healthcare settings. And those cameras would need analytic support behind the scenes to be able to detect opportunities for hand hygiene, such as entering or exiting a patient's room. But then also using that camera, it could assess whether or not somebody performed hand hygiene, but then also based on the temperature changes in their hands that were observed by the camera, whether that hand hygiene was likely to be adequate. Again, lots more work needs to be done on that. I think regarding the Hawthorne effect, the way I like to think about this is that we really do use the Hawthorne effect to our benefit every day.
Agreed.
And to me, while we worry about the validity of our data when people understand that they're being observed, if they know they're being observed for something, that's their opportunity to do it as well as they know as well as they know how to. And if they fail in that setting, it's a great opportunity for us to redirect them to teach them the right way to do something. But also, I think if we think about an automated system to behind the scenes record hand hygiene quality and compliance, people knowing that they're observed. They have become to understand that it's an institutional priority and the importance of doing it. And, that really does help to drive compliance. It does help to drive quality. And, I think we can really take advantage of that.
How do you think that we could pair this method of assessing hand hygiene technique with efficacy in relation to the reduction of the microbes on the person's hands?
I think this is an area that really deserves more research. And as John was saying earlier, one of the key factors in performing effective hand hygiene using an alcohol-based rub is to ensure that you're using the right volume. And we know that people's hands come in different sizes. And for those who have larger hands, it's very likely that larger volumes of alcohol-based hand rub are required to achieve the same microbial outcomes and effectiveness. And we think that this infrared imaging, likely will be able to function as a good surrogate marker. So we hypothesize really that the greater the temperature change, that it is likely to be a more effective antimicrobial. And so it could be a very useful surrogate marker to see how well people are washing their hands, the quality of that hand washing, and that microbial effectiveness. But again, that this is work that still needs to be done to confirm that hypothesis.
So I'm interested in the FLIR or FLIR 1 Pro thermal camera and all the software you guys use. It's really interesting. Was that technology already on the market, or what were some of the opportunities and weaknesses in the current software availability?
Right. The FLIR 1 camera was already available, and so I purchased it online, and the app that goes with it was, of course, already available. So this is a small camera that fits onto an iPhone. So you can see it's a very small device, and it just slips into your iPhone like that. And so one of the advantages of this is that it's portable. And so one could envision perhaps taking it onto a ward and identifying someone who was just getting ready to do hand hygiene. And as soon as they finished, you could approach them and say, hey, could I take a picture of your hands and get an idea of their hand hygiene technique. So that may get around some of the issues about the Hawthorne effect.
Yeah.
If you kind of do it unannounced, you would still face the issue of a Hawthorne effect in an educational setting or another setting, in addition to those mentioned by Dr. Martinello, would be perhaps to use thermal imaging when you're doing periodic competency evaluation of hand hygiene technique.
And I think all of those applications are beneficial. You know, you're avoiding the Hawthorne technique with some of them, but as Dr. Martinello said, the Hawthorne effect can be used to our benefit. So, you know, you're using it as educational opportunities. So there's a lot that can be applied, or a lot of opportunities that can be applied with this. So thank you for that.
Yeah. If I could add, you know, I think one of the benefits that we found with the software that we used was the ability to hone in on different parts of the hand. And that was actually done after the images were taken. And so we were able to very precisely figure out, you know, where do we want to measure these temperatures and have a precise reading. One limitation of the software, though, that is, you know, something that I think would be interesting future work, is to be able to get a composite temperature of the hand. So what is the temperature of one's hand in aggregate? How is it impacted by using alcohol gel? And thinking about the hand as a whole, you know, rather than spot measurements at specific parts of the hand. Because what we don't quite know yet is, you know, what's the most, you know, how much of a temperature drop is necessary to achieve the microbiological outcomes that we need. And also, we don't know exactly where on the hand to measure it, or if a composite measurement, as I mentioned, would be ideal. So work to be done.
Yeah, I might add to Rick's comments there, which I very much agree with. There's a few publications where people have used more sophisticated image analysis software. And what they do is the software will divide the hands and fingers into multiple discrete areas. And then by doing that, we could measure the temperature in multiple different areas, as well as getting a composite reading that Dr. Martinello mentioned. And there is some fairly sophisticated image analysis software. One's available from the NIH called ImageJ, and other people have modified that slightly. There's a version of it called Fiji, and I think one thing we would like to do in a future study is to see if we can use one of those more sophisticated image analysis software programs to look at our thermal images. And so that's something that we're going to think about in the future.
Great. So it sounds like there's a lot of opportunities still left around different areas of this research. But so for our listeners today, are there any key points that you would like to leave them with, things for them to consider in their own practice?
I'll make a comment and then would certainly like to hear what Dr. Martinello has to say. I've thought about what one could do right now to monitor hand hygiene technique on the ward. And probably the simplest thing would be to watch individuals. Maybe this could be done during their routine compliance monitoring activities, but to use a stopwatch function on their smartphone to record how many seconds the person spends rubbing their hands together. And that's, of course, the indication of the dry time, which I mentioned is a very important part of hand hygiene technique. So that, I think, is maybe doable as long as you can see the person throughout the time that they're rubbing their hands together. A more difficult thing would be to see if you could determine if their they're covering their fingers and thumb when they're doing hand hygiene. But I think visually that it would probably be pretty challenging. And so I think that would be a much more difficult thing to do.
Yeah, and I'll just add a few things to Dr. Boyce's comments. One, and I think it's important for our infection prevention staff to be aware of how if they have automated dispensers in their facility or pump dispensers, how they work and the volume they deliver. We know that for the leapfrog assessment, making an assessment of how much volume is delivered by your dispensers is an important part of that assessment. And then, of course, if you're finding that there's either great variability in what's delivered or if there's an insufficient amount delivered, working with the manufacturer of those dispensers to try to see how you can optimize that volume. The other thing that we could do right now is focus on our staff and their behaviors after they receive the dose of the alcohol-based hand rub. And what I mean is that we've certainly seen some of our staff with the sense that there's too much volume being dispensed of the alcohol rub, and they will either pull their hand away and only take a partial dose, or they'll shake their hand to get some of the alcohol rub off of their hand before they rub their hands together, and so on. And so identifying those behaviors and taking the opportunity to redirect those staff to make sure that they not only get all the alcohol rub into their hands, but they're using it appropriately. I think that would be important.
Yeah, I think you're absolutely right. I know that I have myself observed some of those behaviors in the past as well. Yeah. So anyhow, thank you both so much for joining us today. This has been fantastic. And we really, both Nikki and I, are looking forward to what's coming in the future around this research. As we mentioned, I think there's a lot more to come. So we will be hoping to hear from you in the future. APIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at APIC, and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alphin. To hear other APIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at ajicscienceintopractice.org. That's AJIC scienceintopractice.org.